next speaker, who's been a very close collaborator for the last, I think, 3 years. I don't know, time passes by quicker than you want. So Dr. Sujata Kannan is a pediatric intensive care doctor at Johns Hopkins. She and her husband were recruited as a package a few years ago, and they were very fortunate that they were interested in working with us and basically work in nanomedicine. And there's a she'll talk about it. I'm just going to shut up.
Thank you, Ali. Can you hear me? Yeah. And thank you for inviting me to this meeting. It's really been a wonderful meeting. The last 2 days have been great, meeting great people, and great to hear your talks. The other thing I don't have to say this, which I've been really impressed with, is how beautifully this ALD Connect works. I work in a different disease process, which I'll talk about now, and I really wish we could take this and integrate it as well to that too. So thank you for this experience. So I'm actually a critical care physician, so I'm with pediatric critical care, and I also work closely with the Center for Nanomedicine and Kennedy Krieger. So the data, I had to put this disclosure according to the forms that I got. So it's a non-FDA approved agent, and we are co-inventors in all the patents related to this technology. So we've heard a bit about inflammation in the brain and its relationship to various neurodegenerative and neuroinflammatory disorders. And as all of you are aware, this is really an important role. It has a very important role in many CNS disorders. And the three things that I'll talk about is about the role of inflammation, that targeted attenuation of activated glia may be a therapeutic opportunity, and we can achieve this by these dendrimer drug therapies, which are nanoparticles. And as many of you know, glial cells are an important part of the brain. They make up the largest volume of the brain cells, and they have been ignored for a long time, but over the last 10, 15 years, there's been a lot of focus on their function and how they can regulate and modify disease. There has been a lot of work going on in the last decade or so about this, and there have been many studies that have shown that manipulating the glia in the brain can not only, if you attenuate inflammation, you can not only slow down progression of the disease, but that gives you an opportunity for repair and also prolongs the therapeutic window for other therapies to be introduced. So the disorder that I have been focusing on is cerebral palsy and autism, and this is what I've been working on for a number of years now. As you know, cerebral palsy affects many more children than ALD, and however, there has been really nothing, even though it's been around known there's really nothing that can change the progression or the disease as well, except therapeutic hypothermia right now. And about 60% of children with cerebral palsy have other developmental disabilities too, so intellectual disorders, epilepsy, autism is also associated with it. And both in CP and autism, neuroinflammation is a key player, and this has been shown in several postmortem specimens of children with both cerebral palsy and in adults with autism. So our approach for this has been to see if we can can we reach the activated microglia and astrocytes in the brain? If we can get to them, is there a way to attenuate them and to prevent or slow down the ongoing injury? And is there a way that we can switch their phenotype, promote, resolve the inflammation and promote repair? So what are the challenges for this? The first thing is obviously the blood-brain barrier, that a lot of drugs and delivery vehicles don't get through the blood-brain barrier. The other more important thing also is that this is a diffuse inflammation. It's not in one spot like in a tumor, you could just get to it. It's kind of all over, and getting to diffuse cells that are affected in different areas is harder. And even if the vehicle gets through the blood-brain barrier, it has to move through the brain parenchyma, and it has to accumulate in adequate amounts to create a therapeutic effect. And in many disorders, as we know, similar to ALD, the injury already happens by the time the patient presents to you. it's progressed quite a bit, and what can you do after it has happened? Can you do something that'll help reverse it? So I collaborate with my husband, who is actually a chemical engineer. We've been married for about more than 20 years. We've been collaborating for the last 10 years. So no conflict of interest there. So he's a chemical engineer, but he was recruited for the to lead the Center for Nanomedicine at the Wilmer Eye Institute. And he thinks, I don't know if there are any chemical engineers here, but he insists that chemical engineers make the best researchers because they know nothing about anything. So their brain is a blank slate, and they can innovate and think about things very differently. I totally agree with that know nothing part. So what we've been working on are these nanoparticles called dendrimers that are about 4 to 5 nanometers in size. So they are really small. They have multiple branches on their surface, and they are not hard nanoparticles. They're kind of like fuzzballs because there's a lot of space in between, so they can move through spaces. They move through spaces very differently than traditional nanoparticles. And you can attach drugs and targeting ligands to the surface of it to change what it delivers. So our strategy was to see how these nanoparticles behave in the presence of a pathology, and how can we exploit that to deliver different drugs. So just like I said, based on the challenges, the things we would need to do is to make sure that it gets through the blood-brain barrier, and then move in the diseased or in the brain parenchyma. Now, there are many nanoparticles that have been designed such that they can cross the blood-brain barrier, but often they stick along the blood vessels. Moving in the space in the brain parenchyma is tough, and sometimes even delivery into the brain by infusion doesn't achieve a diffuse movement. And moreover, the toughest part is that it has to get taken up by specific cells. So if you want to target some cells, it has to be taken up by those. So that is actually the trickiest part. So what we have found over the last several years is that based on how you engineer the surface, you can make it do all of these things. So just to give you a sense of what the scales of this is. So the size of a nanoparticle is the same as that of a soccer ball if you compare the size of the soccer ball to that of Earth. So if you think about targeting, if you think of the concept of targeting, imagine dropping the soccer ball in the Arctic, ocean, and then expecting it to land here or in Baltimore. So that's really what we're asking it to do, which is a pretty huge challenge. So if we modify these parts, that is, if we look at the nanoparticle properties, we look at what is happening in that disease or that disorder. We have to take that into account. And then, of course, the age plays a factor, too. So the developmental age matters. And then the animal models are also important. So we've actually tried to look at all of these things, and we've looked at different animal models to get a better understanding of this. So what we find is that when we use these dendrimer nanoparticles, which have no charge on their surface, so you can make it with different charges. These are neutrally charged particles. So if you inject them intravenously, we find that if the blood-brain barrier, if in the presence of a normal blood-brain barrier, it doesn't get into the brain at all, it gets excreted completely. But in the presence of some injury, you would see, it gets through and gets into specifically into cells over here. So the red ones are the dendrimer nanoparticles are labeled red. Now, when we compared it to other particles like dextran FITC, 20 nanometer nanoparticles, which are these are standard polystyrene particles that don't get out of the blood vessel even in the presence of injury. And then once it gets through, though, it moves through the parenchyma, and within about 4 hours, it localizes in activated microglial cells. And this is in our model, we see that this is the area of injury, and that's where it localizes. And where there is nothing going on, you don't see any uptake of there. So how would we exploit this? So if you can target the activated microglia and astrocytes, you could potentially affect all of these processes and decrease the injury with this. So the model that I work on is a rabbit model of cerebral palsy. So one of the causes of cerebral palsy is inflammation in utero, and which leads to neuroinflammation in the brain, which is similar to what you see in ALD also, neuroinflammation in the brain. And what happens here is these animals are exposed to an endotoxin 3 days before the babies are born. And we do a surgery, injected along the uterus. These mothers look normal, just like in patients. Moms typically look okay, and the babies are born with brain injury. And these babies have a phenotype of cerebral palsy. So their hind limbs are spastic. They have the spastic diplegia. And this is how a normal rabbit looks. So when we image the brains, we find we imaged it with a ligand for neuroinflammation, PET imaging, and we found that there is increased uptake of the ligand, and we see increased microglial cells in the white matter tracts. And when we administer the dendrimer, which is tagged with sci-fi, which labels it red, we find that you inject it, if you administer it intravenously, it goes to the periventricular region, which is where these activated microglial cells are packed and where they are sitting. So again, it doesn't go into the subventricular zone, it doesn't go into the, into the cortex, but this is the area that it's sitting in. The other interesting thing we found was that the uptake depends on the extent of injury. So the most severe your neurobehavioral deficit is, so this is, the lower score is more severe, a higher score is like normal. So the more severe your injury is, the greater your uptake of the dendrimer is. So which again gives you, if you have a severe neuroinflammation going on, you'll deliver more drug into the brain through this vehicle. So the next step to see is, can we really deliver a therapeutic with this, and can we send the drug to these cells? So we used N-acetylcysteine. It's kind of a simple drug, tried for many things. Lots of clinical trials have been done with it. Has not all been as effective, but it is a very promising agent, and we took it for its antioxidant, anti-inflammatory effects, and also because it can replenish glutathione. My interest was in neonatal brain injury, and this has also been used in pregnancy and in neonates. So the way the drug is conjugated to the dendrimer is with a disulfide bond. So you can put a lot of drug molecules on one molecule of this dendrimer. And the disulfide bond is such that it needs some amount of glutathione to get cleaved. The plasma glutathione levels are very low, and it doesn't stay, because of its small size, it doesn't stay in circulation much. But once it gets taken up by a cell, which in this case is activated microglia and astrocytes, those are the only cells that pick it up. We've looked everywhere and all over. So once it's taken up by these cells, the glutathione acts on it. The drug gets released pretty rapidly into the cell, and then the dendrimer eventually comes out. So I'm just going to show you a couple of animals after we've treated. We've published all of this work before, but the first video is that of a healthy control. Could you run that first video? Thank you. So I'm just going to, we'll go through this first just because people are not used to looking at newborn baby rabbits. They look very different from the cute fuzzy Easter bunnies. They don't really look like rabbits. So this is how a normal rabbit looks. So this is on day 1 of life. They're moving around. They're really active. They're all over the place. They are, kind of walking around quite. They don't start hopping at this age, but their eyes are not open. But they kind of just crawl all over typically. Okay, it's going to change to about 5. When they're about 5 days, their eyes are still not open, but they start hopping. They start looking a little more like a rabbit. Get that white fuzz on, and they hop, and they're still obviously very active. So could you run the other 2, please? Thank you. So these are animals that were exposed to endotoxin in utero. So this is a baby that has a phenotype of cerebral palsy. So the hind limbs are very stiff. They really don't move much at all. And they're trying, though. It's not like they are so sick that they cannot move. They really try to move, but just because of the stiffness, they don't have the balance and coordination. So the other one, so this one got saline on day 1. The other one is the same litter, so it looks about the same. Still is, tries to move, but is not, is not able to do that. And the other one got a single dose of intravenous dendrimer and acetylcysteine. The amount of N-acetylcysteine in this is just 10 milligrams. We compared it to 10 times the dose for the free drug. But this animal just got 10 milligrams of dendrimer and acetylcysteine, and other people who've done work with N-acetylcysteine would know that that's like a nothing dose, really. But to keep in mind, this gets targeted. So you can see at 5 days, this animal is not much better, and typically they don't do well after this. By 5 days, this guy is really pretty active, is doing a lot more like a regular normal rabbit, but not completely the same as this one. But they start hopping and they're a lot more active. And this one is actually just trying to get off the mat.
Yeah.
So when we scored the locomotion, and we found that with 10 milligrams of the N-acetylcysteine tagged to the dendrimer, we had a huge improvement in the motor function. This is where a control animal is. These are all the CP animals, and with the drug alone, you don't see much of an effect. You do see a little bit, but not as much as with the dendrimer. So this is 1 milligram and 10 milligrams of the drug attached to the dendrimer that you see a much better effect with. So this was associated with decrease in the markers of inflammation. We looked at oxidative injury in the protein, lipid, and RNA, and all of that improved too. So even with 100 times the drug alone, we saw some effects with these markers, especially with inflammation, and a little bit with oxidative stress, but it did not lead to improvement in myelination and neuronal counts. So which is why we think the motor function was a lot better with this, and we think the reason is because it is targeted to the cells that are involved. So these are long-term. So what I've shown you till now is what we've published. We have long-term studies that's ongoing, which is funded by our NIH grants, and I'll just show you. Can you run both of them together, just for sake of time? So the long-term studies are a little more challenging because these animals that don't get treated are pretty sick. They don't survive very long. So this is how they look on day 1. Again, this one just got saline. This one got the dendrimer and acetylcysteine at 10 milligrams on day 1 dose. And then you can see, as you see them progress, you'll see as they get older, these guys are just about the same. They don't look that good. This is the same age, day 9. Still a little kind of, a little spastic, the hind limbs, but of course moving a lot more and a lot more active. And as they get older, they really start looking like rabbits now. So they are not I'll show you a comparison with control as they get older. So now this is like a adult rabbit, and they kind of look a lot more normal. They're moving and hopping normally, and we're doing cognitive testing and other things right now to look at it further. Can you run this video too? Thank you. So this one is comparing it to a control. So this is a normal, healthy control here. That's how he looks. So you can see these two are the treated ones, and these two are tinier than this one. So they are smaller. They're actually very cute. They're like little tiny fuzzballs. You can just hold them in your hand. But they look and seem to function the same, but they are smaller in size. So either way, it looks like there's a huge improvement with this therapy. So we're looking at it in different, a lot of other models, and we looked at this with Ali in his hypoxic ischemic model, which we've recently published. And we found that, again, and the thing that we are doing with all this therapy is we're doing a delayed therapy. You create the injury, the injury has already happened, and then we're doing a delayed therapy to see if we can affect a response. So in Ali's model, the injury is at day 5 of age, and this is a hypoxic ischemic insult carotid ligation and leads to white matter injury, and he's worked on this model a lot and published about it. So what we showed is that you treat either at 1 day or 5 days after, even 5 days after the injury, and you get this huge suppression in inflammation, especially in the pro-inflammatory cytokines, and your anti-inflammatory cytokines are not really affected as much. And this was associated with decrease in microglial counts and improved myelination throughout the brain. So even in a delayed time point, we are seeing this response. So I've just shown you a couple of examples of where we've used this. We've looked at it in several other models and also with different drugs. And we are finding a similar kind of, if there is microglial activation or if there is an inflammatory process in the brain, there definitely is uptake in that region. And you can see a response with the treatment. And again, this is a platform which you can use to deliver different types of drugs. So there is potential for treatment or arresting progress even after progress of the injury, even after it's occurred. And what we find is that we think why it works is because it's targeted. It's systemic therapy, it's intravenous, which is easy to administer, especially because it's often we may only need a few doses or doses that are really separated out. And this is, this can work for many, it's a platform which can work for several disorders and many different drugs. And we've tried it again in several different preclinical models. So this is actually our effort at Hopkins. So these are all the different models that we've been working on and that we have preliminary data and some a little more advanced. And we've looked at it in glioblastoma. Of course, CP is where my passion is. A lot in the eye too, where it's showing a lot of promise, and necrotizing enterocolitis disc, TB, and several other disorders. So I really want to thank my group. This is my lab group, and this is the Center for Nanomedicine group, and we work very closely with Kennedy Krieger and the Brain Science Institute at Hopkins. Thank you.
That was fantastic. Beautiful use of scaling to and exploiting of scaling for delivery. So I guess I want to dig a little bit in that term targeted. Okay. So I love the fact that you've got sort of an insight into how things are taken up or targeted. Is that targeting, you said, was contingent on sort of inflammation being present, or the dendrimer being attracted to those cell types that are already in a stage of some pathology? If I understood that correctly, and if so, that's great. But are those cells already too far gone to be rescued? Wouldn't it be better if you got them in an earlier state, where there might be first molecular changes, but maybe not frank inflammation?
So I think most of the time, many times what happens is that this activation is ongoing, but by the time it's probably started long before you see the patient manifest it. So Yes, but you do need to, the advantage of the way I look at it is, the advantage of it is that if you have normal microglia, it is not going to go into those cells. So it will not be going to a normal resting microglial cell, in the chance that would change. So, but if it has undergone some change, some degree of activation, it gets picked up.
And maybe I'm just translating our concepts in the clinical space of going into
pre-symptomatic, yes.
So on a cellular level, there's also something like a pre-symptomatic cell, right? But I completely agree that you're sort of there's a nice selection occurring here. Leslie?
Sujat, very nice work and a beautiful model. I have a question about blood-brain barrier and the migration or passing of that. You showed a nice data about newborns, but you said it does cross blood-brain barrier, and in newborns sometimes blood-brain barrier is not there to cross. So how do you say that it did cross the blood-brain barrier?
So I'm probably going to put Patty in for supporting me for this, but no, the blood-brain barrier actually in newborns is very well formed, right? And even in preterms, I think it's pretty well formed compared to what the general thought is that it's not. However, now in the presence of an insult, are there changes that occur sooner in a newborn blood-brain barrier? That is possible, and probably Patty will be able to talk a lot more about that. How the thing is, it's not that you see this in older animal models too. So I'm showing you our neonatal work because that's where most of my work has been, but you see the same thing in other models. The other thing I want to talk about is we call it blood-brain barrier impairment is really the word I would use, because it's not enough. That impairment, what we are seeing, at least in this rabbit CP model that we have, is not enough to let something like dextran-FITC get through. Dextran-FITC sticks to the vessels. It may be leaking a bit along the endothelium, but you don't see this massive leak like you see in stroke. So it's not like a huge leaky blood-brain barrier. It's just enough of an impairment to let this get through. So the other caveat to it is if it's normal, it's just excreted out. It's not getting into the brain, and you get rid of this in the kidney pretty rapidly.
I have a follow-up comment on a question as well. I'm Patty Musolino from MGH, and I work in vascular interface with the brain. Yes, the blood-brain barrier is pretty much, and as we understand it in humans, even though we don't have complete data on this, we have much better data in mouse. It's around the second trimester of pregnancy, you have already sealed blood-brain barrier with the same characteristics that a mature blood-brain barrier would have. That doesn't mean that you cannot transiently also open the blood-brain barrier. This has been done with echo, ultrasound waves, with heat, with laser beam, and with osmolar therapy. You can do a bolus of osmolar therapy and get the blood-brain barrier open enough. The question here is how much your endothelial cell is going to grab of that and put it out of the brain, the GP systems. They're way more efficient in excreting things outside the brain than in doing anything else. So the question to you, if you have had a chance to transiently open the blood-brain barrier, either, I know with an irreversible insult like radiation when we do the preparation for the mouse, but maybe with something more transient like osmotherapy, do you get your dendrimers to cross that space, and is it excreted again?
So no, we haven't tried to transiently open it, but however, what we've tried to do is in a healthy control animal, inject it directly into the parenchyma of the brain, and you don't see it. It gets out actually into the bloodstream, so you see it in the arachnoid, it's getting out probably into the arachnoid villi or through the interstitium, it's getting out. So it does not stay in the brain, and it does not get picked up by any cells there because there's nothing activated.
And the other question is, and I don't know anything about rabbit newborn brain, the germinal matrix is an immature blood-brain barrier all the way to term almost. In fact, it's a few weeks before term that you still have germinal matrix. at birth might be the area that is most permeable. Have you had a chance to look at the germinal matrix or around the area of the subventricular zone in the caudothalamic groove? I would imagine the rabbit has it in the same place.
Yeah, we do. We have seen it, and you can see it a little. You actually can see it longer in the choroid plexus, which you can see even in the normal animals, but not in the germinal matrix if it is healthy. But again, if there is any exposure to inflammation in utero, it's a completely different game. So, which is why, I mean, our whole focus of this also started with, we have to look at everything. We cannot start a platform or create something looking at normal brain. We really have to look at it in the presence of pathology because everything changes there.
Anna's been waiting patiently.
I have a chemical engineering question. One of the challenges of using dendrimers for drug delivery is that they are not a single chemical entity. There is a distribution of isoelectric points and molecular weights, and they are very hard to produce on large scale. Did you see any issues associated with that? And then, if you did, how did you come up with solutions?
So we deliberately used, earlier we've used mixed, actually we've used polyglycerols and stuff, which are much more, this is a lot more monodispersed than many others are. So we've used that, and we are seeing similar effects. Essentially, hyperbranched polymers seem to do similar things. However, this one, these are, they've scaled up quite a bit on manufacturing this, and we purify this to make sure it's as monodispersed as possible. So for all our experiments with the dendrimer, we make it try to keep it as monodispersed as possible.
Great, thanks so much, Sucharita. And we are now going into coffee break. So one round of applause.